In the autumn of 1944, a German Red Cross nurse named Ketha Reinhardt was captured by American forces near Aachen. She was 23 years old, trained at a military hospital in Dresden, experienced in the economies of wartime German medicine, the careful rationing of morphine, the substitution of paper bandages when cotton ran short, the triage decisions made not on the basis of what was medically optimal, but on the basis of what was available. She was assigned to work in an American evacuation hospital. What she found there, she would describe after the war as incomprehensible. Not the medicine. She was a trained nurse and understood what she was seeing. What was incomprehensible was the quantity. The morphine used in a single day exceeded what a German field hospital might receive in a week. The plasma, the whole blood, the sulfa drugs, and, by late 1944, the penicillin, a drug so scarce in German supply that most German soldiers had never encountered it. She watched an American surgeon operate on a German prisoner of war with the same materials, the same attention, the same standard of care that he applied to American soldiers. This was the second incomprehensible thing. In German medical doctrine, prisoners of war received care after friendly casualties. Resources were allocated first to soldiers who could return to the fight, then to others as supplies permitted. This was not cruelty. It was the logic of scarcity applied to medicine. The American surgeon was not operating under the logic of scarcity. He was operating under the logic of abundance. Reinhardt was not alone. Across the European theater, German medical personnel captured by American forces described the same phenomenon. A system that operated as if resources were not a limiting factor, as if the question was not what could be afforded, but what was medically indicated. They described it with the vocabulary of people who had been living inside a different system, where every ampule of morphine was logged, where blood transfusions were reserved for the most critical cases, where wound infections were treated with whatever was available rather than the optimal agent. The gap between what they had been trained to consider possible and what they were watching happen in the American hospital was, for many of them, the moment when the war became legible in a new way. Not a military war, an industrial war. A war decided not by who had the better soldiers or surgeons, but who had the factories that made morphine, that processed blood plasma, that produced penicillin at a scale that, in 1944, only one country had achieved: the United States. Reinhardt, working in the American evacuation hospital, understood something that the Wehrmacht's casualty statistics had been trying to say for 3 years, and that the German High Command had not wanted to hear. America was not fighting the war the way Germany was fighting it. America was not fighting a war of scarcity. America was fighting a war of abundance. And the wounded, on the American side, were surviving at a rate that German medical officers had been trained to consider theoretically impossible in field conditions. The number was 3%. Of every 100 American soldiers who received medical care in the field or underwent evacuation, 3 died from their wounds or from disease. In the First World War, the American mortality rate for wounded soldiers had been 8.1%. The German rate in the Second World War was comparable. Roughly 1 in 12 wounded soldiers did not survive. 1 in 12 was the professional standard. It was what military medicine at its best had achieved in modern industrial warfare. The Americans had cut it to 1 in 33. Not through better surgeons. Germany had excellent surgeons. Not through better training. German medical personnel were as well trained as any in the world. Through a system built around a specific idea. A wounded soldier was not a lost resource. He was a recoverable one. Recovering him was worth an investment the German system had never been prepared to make. Reinhardt had been trained in a system that made different calculations. She was now watching what different calculations produced. The German military medical system was not primitive. This needs to be said clearly, because the contrast with the American system is not a contrast between competence and incompetence. German military medicine was among the most technically sophisticated in the world. German surgeons were excellent. German medical training was rigorous. German field medicine, in the conditions it operated under, produced results that were professional by any standard. The problem was not the medicine. The problem was the system the medicine operated inside. Germany, in the Second World War, was a country under industrial pressure, fighting on multiple fronts simultaneously, managing a war economy that was never able to produce everything the Wehrmacht needed. Medical supplies competed with ammunition. Blood plasma competed with aviation fuel. Morphine competed with everything. The result was a military medical system designed to function with the minimum necessary to keep soldiers functional. Triage was rigorous and unsentimental. Resources were concentrated on the recoverable. The less recoverable received what could be spared. This was rational. In conditions of scarcity, the only rational approach. What it was not was what Reinhardt was watching across the ward. The American system had been designed from a different premise, that the survival of every wounded soldier who could be saved was worth the full resources required, not the minimum, the full resources. Plasma, blood, sulfa drugs, penicillin, surgery, nursing care, evacuation, all of it, for every wounded man who reached the system. This was not sentimentality, it was calculation. Training a soldier costs money and time. A wounded soldier is a trained soldier. Returning him to health returns that investment. Allowing him to die of a preventable wound loses it and requires a new investment to train a replacement. American military planners had made this calculation explicitly. The medical system was not a humanitarian gesture. It was a return on investment decision. Colonel Paul Hawley, the chief surgeon of the European theater, organized the first military blood bank in history in England in 1943. Blood transfusions saved lives. Blood was finite. Therefore, its supply needed to be managed as a strategic asset rather than an improvised response to individual emergencies. Hawley pooled type-specific blood in gallon containers in England, established a system to transport it to France after D-Day, and created a supply chain that treated blood the way the Quartermaster Corps treated ammunition, available where and when needed. The Germans did not have a comparable system, not because German medical officers were unaware that blood transfusions saved lives. They knew. But the organizational investment required, the planning, logistics, supply chain, cold storage, competed with other military priorities and was never prioritized at the level Hawley had prioritized it. The result was that in 1944, an American wounded soldier had access to type-specific whole blood as a routine part of his treatment. A German wounded soldier, in many cases, did not. The blood bank was one component. The system also included the chain of evacuation, a tiered structure moving wounded men from the battlefield through battalion aid stations, collecting stations, field hospitals, to evacuation hospitals, each step providing increasing levels of care, each step designed to get the wounded soldier to the level of care he needed as quickly as possible. A field hospital performed approximately 80 operations per day. More than 85% of soldiers operated on survived, not exceptional results. The routine performance of a system designed to produce them. Reinhardt understood what she was seeing, the product of a decision made years before the war, by men who had calculated what a wounded soldier was worth and had decided, everything we can give him. She had been trained in a system that reached a different answer. She was watching the difference. On June 6, 1944, Private First Class Thomas Callahan of the 1st Infantry Division was hit by machine gun fire on Omaha Beach. He was 20 years old, from Cleveland, Ohio. He had trained at Fort Benning, crossed the Atlantic in April 1944, and spent 6 weeks in England waiting for the invasion. He went over the side of the landing craft at H hour and was hit before he reached the beach. 2 rounds. Left thigh, penetrating wound, severed femoral artery. Right shoulder, through and through, no arterial involvement. The femoral artery wound was the one that would kill him in minutes if not treated. The medic had trained for precisely this scenario, tourniquet application under fire, the specific sequence that could slow a femoral bleed long enough to get a man to the aid station. He had morphine, sulfa powder, bandages, everything he needed because the Army Medical Corps had calculated, before the invasion, exactly what a medic on Omaha Beach would need. He applied the tourniquet, administered morphine, dusted the wound with sulfa powder, marked the time on Callahan's forehead with a grease pencil, the standard procedure for tourniquet patients, so the next person in the chain would know when the tourniquet had been applied and adjust accordingly. Then he moved to the next man. Callahan was carried off the beach to the battalion aid station. At the aid station, a physician assessed the wound. The femoral artery laceration required surgery. He was loaded onto a DUKW, an amphibious vehicle that could carry casualties from the beach to ships offshore, and transferred to a hospital ship. The ship had operating rooms. It had blood. It had surgeons trained in vascular repair. Within 4 hours of being shot on Omaha Beach, Thomas Callahan was on an operating table. The surgeon repaired the femoral artery. The blood loss was replaced with whole blood from Hawley's blood bank. The sulfa powder applied on the beach had begun suppressing bacterial activity in the wound. Callahan survived. He was evacuated to England, treated at a general hospital in Wiltshire, and returned to the United States in October 1944. He walked with a limp for the rest of his life. He was alive. The chain that saved him had been designed 3 years earlier by a specific, systematic decision made before the first American soldier set foot in Europe, that the chain of evacuation would be organized, supplied, and operated as a strategic priority rather than a logistical afterthought. The same principles that built Sherman tanks at 50 per day were applied to the problem of moving wounded men through a system designed to give them the best possible chance of surviving. The Medical Corps had studied the failures of previous wars. In the Civil War, 50% of amputations resulted in death. In World War I, the rate had dropped to 5% as organized military medicine developed. In World War II, the Americans had set out to push it further still. They had done it by treating the chain of evacuation the way an engineer treats a system. Identify the failure points, address each one, measure the results, adjust. The failure point at the battalion aid station, men dying of shock before surgery. Fix, plasma, carried by medics. The failure point at the field hospital, not enough whole blood. Fix, Hawley's blood bank. The failure point at the evacuation hospital, wound infections. Fix, sulfa drugs, then penicillin. Each failure point addressed, each fix supplied. The chain began with the medic. Every American infantry company had attached medical personnel, trained and equipped for the first minutes after a wound. Then the battalion aid station, then the collecting station, the field hospital, the evacuation hospital, the general hospital. For the seriously wounded, a hospital ship or air evacuation back to the United States. Each link staffed, supplied, and positioned in advance. Each link knowing what the link before it had done and what the link after it would need. The chain moved men through it like a production line for survival. The German soldier who was wounded faced a different chain, not because German doctors were less skilled, not because German medics were less brave, because the system behind them was built on different assumptions and operated under different constraints. The German system had no blood bank. Not in 1944. Blood transfusions were performed in German military hospitals, but they depended on walking donors, often other patients, often soldiers in nearby wards, sometimes the medical personnel themselves. The supply was inconsistent, the logistics improvised, the availability unpredictable. When a German soldier required whole blood, the question was not where in the supply chain to find it. The question was whether any donor could be found at that moment. The German system had no penicillin, not until very late in the war, and even then in minimal quantities. German medical researchers had known about penicillin since the early 1940s and had attempted to produce it. The industrial scale required, the deep tank fermentation process, the purification equipment, the distribution infrastructure, was beyond what German war industry could allocate when competing with ammunition, aircraft, and armor. American pharmaceutical companies, operating in an economy that was not being bombed and had not been depleted by 4 years of total war mobilization, had solved the penicillin production problem by 1943. By D-Day, American forces in Europe had access to penicillin as a standard treatment for wound infections. The German soldier wounded in Normandy in 1944 was treated with sulfa drugs, effective but inferior to penicillin for many wound infections. He received blood transfusion if a donor could be found. He received morphine if supplies permitted. He received the best his system could provide. His system could not provide what the American system provided. The Wehrmacht's medical corps tracked their wounded mortality rate with professional concern throughout the war. German medical officers knew specific interventions, better blood supply, better antibiotics, would reduce it. They could not obtain those interventions at scale. The reasons were industrial. Every resource allocated to pharmaceutical production was a resource not allocated to tanks or planes or shells. American calculations had weighted them differently. It was not that the Americans were better doctors. It was that they had made decisions years before the war about what their industrial economy would produce. And those decisions had included the penicillin, the blood bank, the chain of evacuation, the field hospital capacity to perform 80 operations a day. The wounded German soldier received what Germany's war economy had been able to spare for medicine. The wounded American soldier received what the most productive industrial economy in the world had decided he was worth. This statistic had a second-order effect the numbers alone do not capture. An army that knows its wounded will be cared for fights differently than one that does not. It fights with a specific kind of confidence that is hard to measure and impossible to manufacture without the system behind it. American soldiers had been told, trained, and shown by the presence of medics in every company, by the hospital ships offshore, by the chain of evacuation that moved men from the beach to surgery in 4 hours, that if they were hit, someone would come for them. This was not a small thing. In the specific psychology of combat, the fear of being wounded and abandoned is one of the most powerful forces acting on a soldier's behavior. An army that had minimized this fear had produced a specific kind of morale that the casualty statistics do not fully capture. German soldiers knew their system would try. They also knew it operated under constraints. They had seen the shortages, the improvised transfusions, the absence of drugs that Allied soldiers seemed to have. Reinhardt had drawn her own conclusions. 3%. She had been trained to accept 1 in 12. The difference was not a mystery. The penicillin arrived in France on D-Day. It came in the same ships that brought the ammunition, the rations, the fuel. It was listed in the quartermaster manifest alongside the other essential supplies. It was ordinary, in the way that a new drug that had not existed in any military supply system 5 years earlier could be ordinary. To the American wounded who received it, it was the difference between a wound infection that ended in amputation or death and a wound infection that healed. Alexander Fleming had discovered penicillin's properties in 1928. For more than a decade, it had been a laboratory curiosity. Effective against bacterial infection, but impossible to produce beyond research bench quantities. In 1941, Howard Florey and Ernst Chain published clinical trial results demonstrating that penicillin could cure previously untreatable infections. What their research could not do was solve the production problem. Florey came to the United States to find the industrial capacity that Britain did not have. Approaching pharmaceutical companies in the Agriculture Department's laboratory in Peoria, Illinois, where the deep vat fermentation process that made mass production possible was developed. By 1943, American pharmaceutical companies, Pfizer, Merck, Squibb, were producing penicillin in quantities that were, by the standards of 1928, incomprehensible. Monthly production measured in billions of units. By D-Day, sufficient penicillin had been produced to treat every American wounded soldier who needed it. The German pharmaceutical industry had attempted to produce penicillin. German researchers understood the chemistry and the clinical potential. What they could not produce at scale was the drug itself. German industrial capacity, consumed by weapons production, could not allocate the tanks, equipment, and organizational attention that mass production required. Germany had excellent chemists. Germany did not have enough factories. This was the pattern across every component of the American medical advantage. Not a failure of knowledge or skill, a failure of industrial allocation. The blood plasma that Hawley's system distributed had been processed by American pharmaceutical companies. The sulfa drugs that medics carried in their kits had been manufactured by American chemical companies. The morphine syrettes, individual doses packaged for single-use field administration, had been produced by American manufacturers in quantities that made treating pain a standard procedure rather than a resource allocation decision. Each of these items had a German equivalent. German medicine knew what blood plasma did, what morphine managed, what sulfa drugs controlled. German medicine did not have what American medicine had in 1944. American medicine had the factories, not metaphorically, literally. The factories in New Jersey and Illinois and Ohio that had been producing pharmaceuticals for the civilian market before the war and had been converted, expanded, and retooled to produce military medical supplies at a scale that had no precedent in the history of warfare. Reinhardt, working in the American evacuation hospital in the autumn of 1944, was watching the output of those factories applied to human bodies. She was watching men survive wounds that, in her experience, did not survive. She was watching what it looked like when a nation had decided, years before the war, that keeping its soldiers alive was worth the full productive capacity of its pharmaceutical industry. The sulfa powder that a medic dusted into a wound on a beach in Normandy. The blood that a surgeon pumped into a man who had bled out on the operating table. The penicillin that stopped the infection that, in any previous war, would have killed the man who had survived the surgery. 3%. 1 in 33. The German medical officer who saw the American numbers would have reached the same conclusion as Reinhardt. Not that American doctors were better. Not that American soldiers were tougher. That American factories were more numerous, more productive, and more deliberately oriented toward keeping soldiers alive. In a war decided by factories, the side with better medical factories was the side whose soldiers came home. The Germans understood it. They could not match it. More than 59,000 American nurses served in the Army Nurse Corps during World War II, in field hospitals miles from active fighting, on hospital ships, as flight nurses on medical transport planes. They served under fire. The distinction is not the presence of nursing care, but the deliberate decision to move it forward, to make quality care available at the field hospital level, not just the general hospital in the rear. Part of the same calculation that produced the blood bank and the penicillin supply chain. The result, more than 59,000 nurses, an average of 1 nurse for every 85 soldiers deployed. The investment was in people as much as in supplies, training medics to the specific, teachable skills that determined whether a man survived long enough to reach the aid station, training nurses who recognized complications before they became fatal, training surgeons who performed 80 operations a day under conditions no civilian operating room had prepared them for. The American military had industrialized the training as thoroughly as it had industrialized the supply. Reinhardt had been trained as a German military nurse. Her training was excellent. She was skilled, professional, and experienced in the specific conditions of wartime care. What she was watching was not better nursing. It was better resourced nursing. Nursing that was not making the constant calculations about what could be afforded. She could reach for the morphine without calculating whether there would be enough for the next patient. She could administer penicillin without weighing it against other needs. She could apply the full standard of care because the full standard of care was available. German medical personnel described it consistently. The American system operated as if the question of whether to provide optimal care had already been answered. Not could we afford to do this for every patient? How to do it for every patient. In German hospitals, every treatment was a calculation. Every dose weighed against remaining supply. The Americans had replaced the calculation with a protocol. The protocol said, give him everything he needs. The factories made the protocol possible. The German medical system was not the result of indifference to soldiers' lives. It was the result of different calculations, made under different constraints, with different industrial resources. When Germany went to war in 1939, its economy had been prioritized toward weapons. By 1943, the war economy was under pressure that left medicine at the margin. The margins of a war economy are where the decisions about who lives and who dies get made. America had made different decisions. Not because Americans were more compassionate, because the American economy had the capacity to make those decisions without paying the same price. 60,000 nurses, the first military blood bank in history, penicillin in the quartermaster manifests alongside ammunition. 3%. This was what the margins looked like when you had enough factories. Reinhardt, working in that system, watching those results, understood what had been decided and what had not been decided on the other side. This was the incomprehensible thing. The decision that every wounded man was worth the full resources of the most productive industrial economy in the world. And then the execution of that decision through every link in the chain. 3%. The decision made it possible. The factories made it real. The question that German medical officers could not fully answer was why. Not why the American system produced better outcomes. That was visible in the statistics, the supplies, the chain of evacuation. The why was understandable at the technical level. The question was why America had built the system in the first place. What had produced the specific organizational and industrial choices that resulted in the blood bank, the penicillin supply chain, the 60,000 nurses? The answer was not purely humanitarian. American military culture was not more compassionate than German military culture. The answer was partly practical. The American military in 1942 and 1943 faced a specific problem. It had to build an army of millions from a civilian population with no tradition of military service, train them in months rather than years, and deploy them against professional soldiers who had been fighting for 3 or 4 years. The training pipeline could not produce experienced soldiers fast enough to compensate for combat losses through replacement alone. Every experienced soldier who recovered was worth more than a replacement who had never been in combat. Returning wounded soldiers to health was not just a humanitarian goal, it was a personnel management decision. The Medical Corps had calculated the return on investment explicitly. The cost of training a soldier from induction to combat-ready status was substantial. A wound that took a soldier out of the war permanently lost that investment. A wound that was treated and resulted in recovery and return to duty preserved it. At scale, across an army of millions, the difference between a 3% mortality rate and an 8% mortality rate was hundreds of thousands of soldiers who came home rather than died of their wounds. Hundreds of thousands of experienced soldiers with the specific, irreplaceable knowledge that only combat produces returned to their units rather than their names added to a casualty list. The primary reason was that American military culture had a genuine commitment to the welfare of the individual soldier that expressed itself in organizational decisions. The American soldier was a citizen soldier, and the American government had obligations to citizen soldiers that expressed themselves in budget decisions. Saving the soldier was good ethics and good economics. German military planning had made a different calculation. Not a less compassionate one, but a different one under different constraints. The German tradition of the warrior culture, the acceptance of sacrifice, these were not callous. They were the product of a different relationship between the state and the soldier, a different calculus of what was owed. The German wounded soldier received what the German war economy could spare. The American wounded soldier received what the American war economy had decided he was worth. The decisions had been made before the first shot was fired, before the first soldier was wounded, before the first nurse was posted to a field hospital, in budget meetings, in planning sessions, in the specific organizational choices that determine what a military's medical department has when the war starts. The choices accumulated. The chain of evacuation was one choice. The blood bank was another. The penicillin supply contract with Pfizer and Merck was another. The 60,000 nurses were another. Each choice, individually, seemed like an administrative decision. Together, they produced a system. And the system produced 3%. America had decided the wounded soldier was worth investing in. The 3% mortality rate was the return on that investment. Reinhardt was watching the return. The difference was visible in every ward, every supply cabinet, every patient who walked out of the evacuation hospital on his own feet rather than being carried out under a flag. 3%. 1 in 33. This was what a decision looked like when the factories and the planning and the organizational will to invest in the soldier's life were all aligned. The Germans had the organizational will. They did not have the factories. The Americans had both. The war ended in May 1945 in Europe and August 1945 in the Pacific. The statistics that the Army Medical Corps compiled in the aftermath were, by any previous standard, remarkable. Fewer than 4% of American soldiers who received medical care in the field or underwent evacuation died from wounds or disease. Over 85% of those operated on in field hospitals survived. The chain of evacuation had functioned at the scale of millions of casualties across multiple theaters of war within the parameters it had been designed to meet. The penicillin that had been a laboratory curiosity in 1940 had been administered to hundreds of thousands of American wounded by 1945, preventing the wound infections that had killed soldiers in every previous war. The blood bank system that Hawley had organized in England in 1943 had supplied whole blood to surgical teams across the European theater, enabling operations that could not have been performed without it. The 60,000 nurses had served on every front, in conditions that their pre-war training had not prepared them for, and which they had handled with the specific professionalism of people who had been given a job and had done it. The mortality rate was 3%. The number had been achieved. It had been achieved by design. And its achievement had strategic consequences that went beyond the individual soldiers it had saved. The German army that the Americans had faced in Normandy and in the final battles of 1944 and 1945 was an army depleted not just by combat losses, but by the specific inefficiency of a medical system that could not return as high a proportion of its wounded to duty. Every German soldier who died of a wound that an American soldier would have survived was a German soldier who could not fight again. The American medical system was not just saving American soldiers, it was, indirectly, degrading the German force. This is not how the medical system is usually described. Medical care is described in humanitarian terms: the value of human life, the duty to the wounded, the professional obligation of military medicine. All of these were present in the American system. They were real and they mattered. But there was also a strategic dimension that the 3% mortality rate represents. An army that consistently returns a higher proportion of its wounded to duty has more experienced soldiers available at any given moment than an army that does not. Experience is not replaceable. A soldier who has been under fire, who has learned the specific unteachable knowledge that combat produces, is not equivalent to a soldier who has not. The American system was producing more of these soldiers, continuously, by keeping alive men who would otherwise have died. The German system was producing fewer of them. Reinhardt returned to Germany after the war. She had worked in the American hospital for several months, long enough to understand the system, to absorb its principles, to see what it produced. She brought that understanding back with her. The post-war German medical system incorporated lessons from what German medical personnel had seen in American facilities, not as direct imitation, but as the kind of professional influence that flows from watching something work. 3%. 1 in 33. The number did not come from better surgeons or braver nurses or more compassionate commanders. It came from decisions made in budget meetings and planning sessions before the war began. Decisions that expressed a calculation about what a wounded soldier was worth. America had decided he was worth everything the most productive industrial economy in the world could provide. The factories had made it possible. The chain had delivered it. 3%. That was the answer German medical officers could not provide from within their own system. And the answer German POWs saw when they first walked into an American field hospital and realized, with the specific clarity of people confronting a world organized on different principles, what a nation looks like when it has decided that its soldiers are worth saving. The German POW who first walked into an American field hospital was usually expecting something different. What he expected was what he knew: rigorous triage, careful rationing, professional competence under the constraints of a war economy that had not prioritized medicine. What he found was a field hospital that looked like something else: organized, supplied, operating at a standard that, in his experience, was not what field medicine looked like. The reaction was not of someone who had discovered the Americans were better doctors. It was of someone who had discovered the Americans operated inside a different set of assumptions about what medicine owed the wounded man. The assumptions were visible everywhere: in the supply cabinets that were full, not carefully rationed; in the medics who administered morphine without hesitation, without calculation, because the supply was sufficient to treat every patient who needed it; in the penicillin that was used routinely for wound infections, not husbanded for the most critical cases because more was coming on the next supply convoy; in the blood that was available when a surgeon needed it, because a colonel had built a blood bank before the invasion and had made sure that blood was treated as a military supply, the same as ammunition. The assumptions had been built into the system before the first patient arrived. This was what incomprehensible meant when Reinhardt used the word. Not that the medicine was beyond technical comprehension, but that the assumptions about what a wounded soldier deserved, about what it was appropriate to spend on keeping a man alive, were outside the framework her experience had given her. German medicine operated inside a framework of scarcity, not because German doctors were indifferent to the wounded, because Germany had gone to war with an economy that prioritized weapons. American medicine operated inside a framework of abundance, not because American planners were more virtuous, because America had the most productive industrial economy in the world and had made specific decisions about what it would produce for its soldiers. The decisions had produced the factories. The factories had produced the penicillin and the plasma and the morphine. The penicillin and the plasma and the morphine, administered through the chain of evacuation, had produced 3%. 3%. The number that German medical officers could not match, and that German POWs confronted when they were brought into American hospitals and treated with the same standard of care as American soldiers. Treated. This was the third incomprehensible thing for many of them. Not only the abundance of the supplies, but the fact that the supplies were being used for them. That the morphine and the penicillin and the whole blood were available to enemy prisoners at the same standard as to the men who had captured them. This was the logic of abundance carried to its conclusion. When there is enough for everyone, the question of who deserves it becomes simpler. There was enough, so everyone received it. The German soldier in the American hospital, wounded, captured, treated, was receiving the output of a system that had been designed years before the war by men who had calculated what a soldier's life was worth. They had decided it was worth the full productive capacity of their factories. His wound was being treated with drugs his own medical corps could not provide in equivalent quantities. His blood loss was being replaced from a supply his own surgeons could not access reliably. His pain was being managed with a drug his own medics had to ration. He was being treated the way the Americans treated their own men, not because the Americans had no enemies, because the Americans had enough. The recognition that crossed the faces of German medical personnel when they first understood what they were looking at. They were inside a system built on assumptions their own system had never made. And those assumptions had produced what their own system, for all its professional excellence, had not been able to produce: 3%. the factories, the decisions, the return on the investment. The number 3% has a lineage. In the Civil War, mortality for wounded American soldiers was approximately 13%. In the First World War, 8.1%, essentially unchanged over 2 decades because the fundamental constraints had not changed. Antibiotics did not exist. Blood transfusion was experimental. The chain of evacuation was improvised. Between 1918 and 1945, medicine changed. Penicillin, sulfa drugs, blood banking, plasma, triage protocols that could be taught and applied consistently rather than left to individual judgment. The American military absorbed these developments and built a system around them. The 3% was the result. The lessons were incorporated into Korea, Vietnam, the Gulf War, every subsequent conflict. In Iraq and Afghanistan, the wounded to killed ratio reached levels incomprehensible to a World War II surgeon. Soldiers surviving wounds that had been reliably fatal in 1944. The trajectory was visible. Invest in the medical system, and more soldiers survive. The investment returns. Reinhardt returned to Germany and became a hospital administrator in Munich, incorporating what she had learned. She understood that what she had watched was not magic. It was the output of specific decisions, made years before the war, about what an industrial economy would produce and what it would value. Decisions made by people who had done the calculation and concluded that keeping soldiers alive was worth the investment. The answer to the question asked implicitly at every level of the system, from the medic on the beach to the surgeon in the evacuation hospital, to the nurses monitoring the post-operative wards. The question was, what is a soldier worth? The American system had answered before the war began, in the decisions about penicillin production and blood banking and the chain of evacuation and the 60,000 nurses. The answer was everything. Not rhetorically, specifically, industrially, logistically. The full productive capacity of American pharmaceutical companies, the full organizational attention of the Army Medical Corps, the full supply chain that Hawley had built. This was what German POWs saw. Not better doctors, not more compassionate commanders. A system built on the assumption that the wounded soldier was worth everything the most productive industrial economy in the world could provide. Germany treated its wounded as a cost of war. America treated its wounded as an investment. The German POW in the American hospital was experiencing the answer. His wound being treated with everything the system could provide, not because he deserved it in some abstract moral sense, but because there was enough. And when there is enough, everything becomes possible. 3%. The factories made it possible. The decisions made the factories possible. And the men who made the decisions had made the right call. Germany treated its wounded as a cost. America treated its wounded as an investment. The investment paid off. 3% died. That was the difference. That was what the German POW saw when he walked through the door in 1944. He saw the supply cabinets. He saw the medics who did not calculate before reaching for the morphine. He saw the operating rooms performing 80 procedures a day. He saw the nurses, 60,000 of them across the entire theater, monitoring patients, managing complications, providing the specific, continuous care that turned surgical survival into full recovery. He saw the blood bank. He saw what it looked like when a nation had decided its soldiers were worth everything. And he saw what that decision produced. Every soldier. Because there was enough. Because the factories had made enough. Because someone had decided, years before the first soldier was wounded, that the factories should make enough. The wounded German soldier in the American hospital was receiving care from a system built for his enemy. He was receiving it anyway, because there was enough for everyone, because the investment had been made, because the factories had produced. 3%. 1 in 33. That was the difference. That was the answer. That was what he saw.